There's a lot going on in the pelvis. There's so many different organ systems in one small space, and there's a lot of interaction.
In my medical practice, one of the recurrent issues that my clients struggle with and come to me for assistance for time and time again is pelvic pain. This has been a predominant problem that keeps women from enjoying their lives, whether it's from endometriosis or musculoskeletal issues, or whether it's from trauma. Pelvic pain can affect us in so many ways, and often women are sent on a journey without any real solution. Now, I went to medical school as an osteopathic physician, and I learned how human physiology is linked to our anatomy so intricately and how every piece is connected. So when we are dealing with pelvic pain, we have to address the musculoskeletal issues and not just try to manage the pain. Focusing on the pain only leads to more complications as we are only addressing the symptoms. We need to address the underlying key issues causing the pain and find ways to decrease inflammation, balance hormones, and restore normal anatomy. And so today, my guests on the Girlfriend Doctor show are both physicians specializing in pelvic rehabilitation medicine. Their expertise lies in helping women out of pelvic pain and recover and become pain-free. This is a life-changing approach. It changes the way we move, the way we exercise, the way we express intimacy and our sexual function. And today we will show you some tools and tips that are super handy and that you can do yourself right away to improve pain and function, and that will increase the quality of your life.
Today I want to talk about a very important topic that doesn't get talked about enough. In fact, it's often covered in shame and self-consciousness, and we can feel effeminate. We can feel like we're losing our femininity when we're dealing with this problem. And it's not just for women, but it's also for men. And this is the area of pelvic pain and pelvic pain issues. So I'm here in this beautiful center, the Pelvic Rehabilitation Center, with this beautiful doctor, Dr. Allison Shrikhande. And we're in Dallas, in her clinic here in Dallas, and she has been on this mission to heal pelvic pain and to make it a part of our conversation as couples. Women often deal with pelvic pain post-childbirth, post-surgery, just part of life. Athletes particularly can have a very tight and painful pelvic floor. So we're going to talk about some of these issues. Allison, it's great to be here with you today.
Thank you, Dr. Anna. Thank you for having me. I'm really excited to be here.
Well, talk about this, why you created the Pelvic Rehabilitation Medical Center, and the types of patients that you see on a regular basis.
Sure. Yeah, this came out of honestly a necessity for myself. My final year of residency training, during my first pregnancy, I had postpartum pelvic pain, pelvic floor muscle dysfunction, a lot of pain with intercourse that continued after, my classic 6-week follow-up, some bladder issues, urinary urgency frequency, some intermittent burning, and some bowel constipation, difficulty having bowel movements. All are kind of our classic pelvic pain, pelvic floor dysfunction patient that we see. And this silent disease process doesn't show up on any imaging, blood work. Cultures were all normal.
Exactly.
So it's a challenge, right? And,
yes.
So I was offered opioids, and really that was it.
Just pain meds, and
some
deal
pain
with
meds,
it.
And that's how it is. You had a baby.
You had a baby, right?
Had a baby.
Right.
But I found this amazing pelvic floor physical therapist who really just opened my eyes to the world of pelvic pain, the pelvic floor. And as a doctor in PM&R, a neuromuscular doctor, right, a non-operative neuromuscular doctor, we didn't learn anything about it, which is interesting to me. So I was fascinated by it, and then that's how it all started.
Well, you're a classically trained physiatrist, and so neuromuscular medicine, that's key. Talk about that, exactly what that means, because some people don't realize, other than neurology and neurosurgery, that there's a whole non-surgical field looking at these issues.
Yeah, exactly. So as a physiatrist or rehab doc, PM&R doc, we're named several things. But yeah, we're non-operative physicians who focus really on the nerves and the myofascial system, really. And we're not trained necessarily in one organ system. We're really trained to look at the interplay between the different organ systems with each other, and then the different organ systems with the nervous system, and then with the myofascial system. So that's how we look at problems in patients, and that's how we diagnose things. And I think that's perfect for the world of pelvic pain, given there's a lot going on in the pelvis. There's so many different organ systems in one small space, and there's a lot of interactions with both the peripheral nerves, the central nervous system, right, and then the muscles and the fascia. So that's why I think looking at it that way is what we do. That's the approach that we bring at pelvic rehabilitation medicine.
Well, for me too, as an obstetrician in residency, I was pregnant with my daughter, Amanda, and I had pubic symphositis, and I didn't even know what that was. I hadn't studied it in med school as an OBGYN resident. I didn't know what that was until I experienced it myself. And in talking about pubic symphysis pain, the pubic bones join together like this. Let me bring up the handy dandy pelvis. There is connective tissue just between these two pubic bones. So the right and left side, right? So it's connected by this small connective tissue, and that can get inflamed, soft, because of the hormones in pregnancy, high levels of progesterone, high levels of relaxin, and this just can get, just like if you've ever had a bad cold and it hurt every time to cough in the ribs. We call that costochondritis. That's what it feels like in the pelvis. And it feels like that every time you walk. It can feel like your pelvis is actually splitting apart. Right,
yes,
Allison?
Yes, I know. And it is a joint just like any other joint in your body. So you have that synovial fluid and it does move. So it seems like it would be fused, but it's not, right? And that's what makes it's great for our flexibility, but it can be challenging in pregnancy.
It can be. And so this is a really important area. So women will struggle with that. And then not to mention just with childbirth in general, those hormones help the pelvis relax to have a big baby delivered through the vagina, but sometimes there's an episiotomy, sometimes there's a fascial tear. Even if you didn't have necessarily a tear or cut exteriorly, there can be a tear interiorly. And depending on how that heals can cause scarring, pain, and it may not be seen. So you may be told everything looks normal. There's no issue, but if you're having pain, there's always a problem.
Exactly. I think that's the number one thing. If you know your own body, and if you feel something's off, pain, discomfort, function issues, tell somebody, speak up.
Yeah, and keep looking for answers. Keep looking for answers. So even like also pain with intercourse. So there are a lot of reasons for pain with intercourse. And you always talk about you take care of this triangle, this sling. Right. So do you want to talk a little bit about some of the reasons for the pain with intercourse as well?
Really, postpartum, the most common reasons after having a baby are really some muscle nerve dysfunction can cause pain with intercourse. Essentially, after having a baby, the muscles really we describe it as hypotonic or hypertonic, right? Where the muscles are either in spasm, so short, spastic, and weaker still, not supporting the organs, or hypotonic, where they're kind of loosey-goosey, so they're extended. So those are the two kind of options postpartum. Hypertonic is where the pain with intercourse would come, because quite often they're putting compression on those nerves that are involved with intercourse, right? So when they compress those nerves, the nerves start to get inflamed and they start to fire when they shouldn't. And then you have discomfort either during intercourse, sometimes it's superficial right at the entrance, or sometimes it's deeper, right? It can be either, or it can be both. And sometimes it's honestly soreness post-intercourse, right? I'm doing okay, but then after I have a lot of soreness, pain, or my bladder flares after. All of that can come from that muscle nerve kind of dysfunction. With carrying a baby is challenging on the pelvic floor muscles and nerves, and then delivering a baby is also challenging. It puts a lot of pressure on the muscles and nerves. So pain with intercourse, yeah, a lot of different reasons that we see it. The most common ones, there may be underlying gynecological things such as endometriosis, very common in our patient population. Sometimes fibroids or even PCOS can cause kind of some chronic guarding in the pelvic floor muscles, which then again irritates the nerves. So that's our job, is to really release that guarding, release that inflammation and irritation of the nerves, and see how patients do. Those are.
And even like endometriosis and adenomyosis, pain post cesarean section, is another issue that sometimes goes undiagnosed, untreated, undiscussed. Because again, we've got this great reward, this amazing baby, right? But we're still having these pain symptoms. And again, it's not something we should ever live with. So the same issue, right? The change in the muscle, the nerve spiring, that does chronic pain stimuli.
100%.
That's aggravated by activity or anything.
Right. It can be aggravated by activity, and then having a baby as well can aggravate it all. Right. Yeah. So same underlying issues. So we work kind of with PM&R, with pelvic floor physical therapy to really resolve that muscle nerve dysfunction, and really get patients having intercourse again and enjoying it, right? Because a lot of patients feel they have to live with it, or sometimes it's just positional. So they'll try to do certain positions, but it takes away from their sexual life
Spontaneity.
and health and spontaneity, right? So you don't have to live with that either. It can be that, we want to make it so that any position is comfortable and exciting, and and improving orgasm, really, when you improve the health of your muscles and nerves. It's all involved in the process.
And this is a really, again, specialized area of medicine. And so we're looking for an answer to this problem. And it's, again, we can't get an answer if we're not asking the questions and we're not continuing to advocate for ourselves. Women, you guys have great intuitions, right? You know that if you're experiencing something, whether you're told that's normal or not, keep digging for an answer.
This episode of the show is sponsored by Julva. Julva is an all-natural anti-aging cosmetic cream for your delicate feminine parts, created by triple board certified OBGYN Dr. Anna Cabeca. If you want to stop embarrassing urine leaks, reduce vaginal discomfort and dryness, and reignite your intimate relationship, try Julva today at dranna.com and use the code SHOW10 to get 10% off your first order.
So we're going to go into the exam room now. We're going to talk about pain with pregnancy and some of the treatments that we can do postpartum. And I've had women in my practice as a gynecologist that had a baby 20, 30 years ago and were still struggling with pelvic pain. So this is true at any age. We don't necessarily need to know where did it start, but we're going to fix it no matter where it came from. And the other issue, the topic that we're going to talk about and go over in the exam room too, is when we have significant, atrophy and that hypertonic muscles, and what is treatment? What is pelvic floor rehabilitation? What does that look like? And how do we treat that with manipulation, with injections? What are some of the state-of-the-art therapies that, thanks to Allison's own personal journey, she's able to share with us today?
Yeah, so you have pain with sitting for a couple reasons. Number one, if you see, this is your pelvic model, okay? And we'll turn it around to the back, the posterior aspect. And you have pain here, and it's your tailbone, otherwise known as your coccyx. We call this the sacrococcygeal joint. So the pain's actually in the joint here. And it came from when you described how you fell on that tailbone, and that can cause this coccyx to get a little inflamed, and sometimes it can actually turn kind of in and under. And when you sit down, it's going to stretch this joint, which has pain receptors in it, and it's going to cause you pain every time you sit. So that's one reason why you're having some pain when you're sitting. The other reason why you're having pain when you're sitting. So when you turn it back to the front, this pelvic model is made up of both joints, bones of the pelvis, and then muscles of the pelvis. So the main joints of the pelvis, you have this pubic symphysis joint in front, okay? Then you have the two hip joints on either side here, sits in the acetabellum. And then on the back, you have your sacroiliac joints, one here and one here between your sacrum and your iliac bone. Those are the muscles and the joints. Now, to hold up the pelvis, you have the muscles of the pelvis. The main ones are called the Levator Anai Sling. The sling, if you look at it this way, goes from the coccyx in the back all the way to the front to the pubic symphysis. So it's a big hammock of muscles, okay? It's called the Levator Anai Sling. It's made up of the three major muscles called the iliococcygeus, pubococcygeus, and puborectalis. So if you take away, the organs sit on top of this sling. So the sling is very important and really holding up not only the important organs in your pelvis, which you have your bladder, and you also have your vagina and uterus, and then your rectum, your descending colon here, okay? So if you remove these three really important organs, you can see the muscles better. If you look into it, these are the main muscles of that levator, Anai, Sling, right? So why do you have pain with sitting in addition to your coccydynia or coccyx pain? These muscles that you have here are squeezing these nerves that really are involved in sitting. So when you sit down, there are two main nerves, the pudendal nerve and the posterior femoral cutaneous nerve that go around here and around your sit bones. And if you're sitting down, you're squeezing those nerves and they're already being squeezed by the muscles. So those nerves aren't happy. So those are the two reasons that you're having issues with sitting. So what we're going to do is really work on both. We're going to work on creating space around so those muscles aren't squeezing and putting pressure on the nerves. And we're also going to work on what we call rectal mobilization, where we make sure this little joint here, the sacrococcygeal joint, not being irritated or pulled, both by the muscles and the fascia around it. So that's how we're going to get you better.
Awesome. Okay. So then what are next steps when you're working with this client?
Well, you were sent from your pelvic floor physical therapist for help because you have tried a course of pelvic floor PT. You've made some significant gains, but you're still having some issues. So you've plateaued, we call it. So now we're going to have you continue working with your pelvic floor physical therapist once weekly. And it's going to be really a 6-week protocol where you see us once a week and pelvic floor physical therapy once a week. Now, in addition, what we're going to start you on is a muscle relaxer suppository, short term, just while we're treating you, made of Valium and baclofen muscle relaxers to really help you tolerate pelvic floor PT, because your physical therapist said it was a bit uncomfortable for you. So just take it once a day at night right before bed, but it will really help you get better faster, and we'll do it just for 6 to 8 weeks, short term.
Breaking that cycle of the nerve pain, right?
Right.
Breaking that cycle of the nerve pain, it really helps. So relaxing the muscle, but also relaxing the signals that we're getting that are constantly keeping the pain, turned on, the muscles turned on or the nerves turned on. And those rectal suppository, that can be game changing. Really nice.
Completely agree. And because your symptoms haven't been going on for that long, it's been about 8 months, we're actually going to we often use nerve medications to help break the cycle as well. Of course, there's muscle and nerve dysfunction, right? So I'm going to put the nerve medication in your suppository. So we'll just start there. So your suppository will have muscle relaxers and a medication to really help reset that nerve signal. What we're going to add is something called gabapentin. So it'll be gabapentin 300 milligrams in the suppository for the 6 to 8 weeks. So we'll do that. In addition, with everything that you have going on, I want you to do breathing at night. So diaphragmatic breathing to really help reset that parasympathetic sympathetic system, which is really upregulated right now. So you're kind of subconsciously tensing your pelvic floor muscles, mainly because you're in pain when you're sitting, which is understandable, but we need to really down-regulate the central nervous system, and that breathing is where we're going to start. So every night before bed, I want you to do your diaphragmatic breathing, where you put your hand on your belly, take a deep breath in, and your belly should raise and out, and your belly should come down. Okay, so in through your nose, out through your mouth. 10 times. Do it every time you wake up in the morning, every time you go before you go to bed. If you have time, you can do it also in the middle of the day. 3 times a day. We'll really work on retraining, resetting, and down regulating. Okay. In addition to this, we're going to do a series of external ultrasound-guided peripheral nerve blocks and trigger point injections, where we treat one side at a time. So it'll be 3 on the right, 3 on the left. And what we're going to do really is, I'll show you in this picture because it's a little easier.
Okay.
So we are going to treat, the nerves that we'll treat are the pudendal nerve here, which is at what we call Alcock's canal, okay? And it gives off 3 main branches, the inferior rectal branch, the perineal branch, and then a dorsal nerve to the clitoris. But we're going to treat it before it gives off the branches at Alcock's canal. In addition, we're going to treat the other main nerve of the pelvis that is going to be irritated when you're sitting, is the posterior femoral cutaneous, which is right next to the pudendal nerve. And there's a lot of crossover and crosstalk between these two nerves and cross-innervation. So we treat them both so they don't upregulate one another. And the muscles we're going to be treating are the muscles of the Levator Anai Sling, puborectalis, pubococcygeus, and iliococcygeus. And for you, we may add the obturator internus because on exam, your external rotators were tight, and I think they're pulling on the coccyx, which is very common with coccydynia patients. So it's just each muscle just gets treated one time, and it's trip around the pelvis, and we do right side one day, left side the next day. And we keep going back and forth, go straight to work, no downtime, ibuprofen, some ice, and then you just go on with your day. And then you'll go to physical therapy also that week. Very important to do it together.
I think too, just for anatomy too, when we're looking at this, like looking at the injections, you're injecting in here, and then also laterally out here.
So the way we do it is first you're lying on your back with your knees bent, and we're treating externally right here under ultrasound. And then we actually stick on that side, we have you flip over. And that seems to have been when patients started to get better, is treating this way when you have them patients flip, and then you treat from the back and you go into Alcox, again, one side at a time. But that's how you do it. So first you'll be kind of lying on your back with your knees bent, and then you'll be lying on your stomach, all on the same side. The other benefit of treating just one side at a time is you can actually see your improvement as we go. You'll say, oh, okay, now do the left because the right feels a little bit better. So that is how we approach it, all external under ultrasound.
Yeah, that is perfect. Thank you. And then just again, it's not pain that we have to live with. It's not something that, because if we don't address it, like especially with pelvic floor physical therapy and looking at this chronic, persistent, has not resolved on its own pain, that scarring, that signaling, you can see where the nerves are coming up through in that picture was so clear. But the pudendal nerves coming up innervate the vulva, innervate the glands, innervate the clitoris, and then sexual dysfunction, decrease in orgasm, pain with intercourse, all of that continues to evolve or get worse or not get better over time. And again, addressing it as early as possible. But is it ever too late? Is there ever chronic pain that you can't improve in that?
Those are our most challenging patients. It's really based on the chronicity of the pain. So too late, it's too late. We never want to say that. But if it's going on, more than 5 years, it just becomes your new normal, really gets imprinted in your mRNA. So we describe it like an iPhone. We are trying to reboot you. We're trying to turn you off, turn you on, and reset the signals. That's really what we're trying to do. And it's something called neuroplasticity. So your nervous system can change, which is great. But sometimes it just takes more time is how I would look at it than other times. And then conceptually, and what we're doing in our protocol, we're not magically fixing the nerves. What we're doing is creating a better environment. They're less inflamed, less restricted, more mobile, and then they can heal. Once they get more blood flow, less inflammation around them, they start to fire less. They stop that aberrant firing of those peripheral nociceptors. They start to be more normal, right? But it takes some time. But that is classically what we're doing. Once a week, 3 times on each side. And then you don't see us for 6 weeks. You just go to your physical therapy and sometimes continue your suppository, and then they heal during that time. And then when you come back, we do a full exam again to just see all the progress that we've made in both the muscle and the nerves.
Love it. And then also with this, like with pain, any pain issue, you want an anti-inflammatory diet. So you guys know, I'm going to tell you keto green. Get Keto Green 16. My book, 16-Day Plan, will kickstart you really strong anti-inflammatory program. So that's a good place to start. Well, I thank you for sharing that. We're going to heal the coccyx pain, pelvic floor pain, because that's still the same process for so many clients.
Thank you for watching this video. Be sure to subscribe to my YouTube channel here and get those notifications, and comment below. Let me know your thoughts, what you loved, and what your action step is.